I'm David Waters. I'm the Chief Executive of the CAA. It's great to have you all here. So we're winding down to the end of the masterclass, and I think it's very fitting that we've talked a lot over the last 2 days through the Research Academy and the masterclass about how we can improve the system to save more lives. But one of the common themes that have come across in most of the presentations that I've been in is that the patient is at the center of everything we do. And we must always remember that the patient comes first. And on that very theme, I would like to introduce Dr. Lynn Gardner. Dr. Lynn Gardner is a survivor of cardiac arrest, and he's going to share his story with us. So welcome to the stage, Lynn.
Thank you, and good afternoon. As my name has already been bandied about with Dr. Arnold, I won't go there any further, but I would like to thank SAS for the opportunity to share this part of my story with you, as it demonstrates and highlights the benefits of rapid restoration of cardiac rhythm and sustainable circulation. First, some background. I graduated from Adelaide University in 1968, completed my RMO year at the Queen Elizabeth, and in January 1970 my wife and I arrived in Queensland, where we began a 5-year tour of duty as an RAAF medical officer. The last 3 of those years were spent in Western Australia, and we returned to South Australia with 2 daughters. After some revision and upskilling in obstetrics and paediatrics, we searched for a rural practice not too far from Adelaide. Eventually, we decided to start up a practice in Yankalilla. Yet those days, the Flinders Medical Centre was not fully functional. Sounds like a bit of an echo there with the RA. And the ambulance services were provided by volunteers under the guidance of the South Coast branch of the St John Ambulance Service. The nearest hospital in those days was the South Coast District Hospital, staffed by the general practitioners in Victor Harbour, and then it was the Royal Adelaide Hospital. The road running time in an ambulance was probably, from Yankalilla by itself, about an hour 15, and if it was at Cape Jervis, which is an extra 30 kilometres south of south of Yankalilla, you could be 2 hours, 2.5 hours before you could actually get a major injury to hospital. So it really came to no surprise to us that in that first 12 months we had 12 road fatalities. 42 years later, we've only had 1 in the last 24 months, and that is 1 too many. My association with what was to become SA Ambulance Service began as a support to our local volunteers, offering them encouragement, assistance with training and hands-on help in road crash rescue, vertical rescue, and sometimes marine rescue when that was requested. Subsequently, with the development of the centralised career-staffed ambulance we know as SAS, and the introduction of paramedics with advanced life-saving skills, aeromedical rescue retrieval, and improved training of our volunteers, these developments have led to many lives being saved that would otherwise have been lost. My continuing involvement with the local ambulance crews at life-threat incidents has been echoed in other rural communities, particularly where there is no local hospital. This process was formalised by Country Health SA in 2007 by the establishment of the Rural Emergency Responder Network, where SAS provided medical kits, associated drugs, and significantly remuneration for providing these out-of-hospital services to major life threat. And the predominance of those, of course, in our area was road crash. In the first year of RERN, there were 10 members and 13 events. Last year, I am told, there were 33 members providing these services, and the total was 92. This leads me to the 25th of January 2012. I was paged to assist a crew in a tractor rollover a couple of kilometres outside of Yankalilla. I remember responding and turned off Main South Road into Fitzgerald Road, approximately 1 kilometre from that scene. My next recollection was being unable to move, open my eyes or speak. I then heard my wife saying, "Be still, you're in an ICU, intubated, you've had a heart attack." I later found out that this was 4 days after the call-out and that my anterograde amnesia in relation to that call-out was about a half an hour. So I can't tell you anything about the event up until I was extubated in ICU. I have managed to glean the process of what happened from the crews that were working there, and what happened apparently was, I arrived, I assessed the patient who was conscious and stable hemodynamically, clearly had a pneumothorax and was hemodynamically stable. I still cannulated him, administered IV analgesia, and as the pneumothorax developed signs of tension, and it was evident that he was going to need a finger thoracostomy, I did hear the approaching helicopter bringing a retrieval team. So I felt that a finger thoracostomy from me could delay until a retrieval doctor was there with a chest tube. Anyway, I met the retrieval team met me, and I handed the patient over to the doctor, then stood up, turned around and did a face plant. It was a VF arrest. The CFS captain was adjacent to me and called the event and then began CPR. So, as we've all heard, the quicker you get the CPR, the better things are likely to be. Even better than that, of course, was the fact that there was a retrieval team there with a defibrillator, and it was a matter of probably 1 or 2 minutes after the arrest that one defibrillation succeeded in a return of sustainable circulation. The retrieval doctor was Dr. Catherine Pash, who I think is hiding up there somewhere. She is now, as most of you know, the principal ambulance medical officer for SAS. A second retrieval team was obviously needed to be mobilised to manage the original casualty, and during that interval I was intubated and anaesthetised. 2 helicopters then flew to FMC in formation. That was an uncommon sight, and by gosh, I wish I could have seen it. Coronary angiography at Flinders revealed a dominant left circumflex with 90% occlusion by a ruptured plaque. This was stented. There was also some significant stenoses in 2 other vessels, but they decided not to stent those. Even with the retrospectoscope, I have been unable to identify any symptoms prior to the event that I would recognise as angina. And my risk factor profile was relatively benign. There was a possible positive family history. I was a male in the 60s, an ex-smoker, and confirmed hypocholesterolemia, and I'd been on long-term low-dose statin. Wind the clock forward 6 weeks from the arrest, and although I then felt very well, I failed a stress echo before returning to work, and further coronary angiography confirmed the significance of the distal disease in those 2 other vessels, and a double bypass followed shortly after. I then succeeded in convalescence and returned to work in May. I was also able to return, excuse me, I was also able to return to responding for RERN in the following 2 or 3 years, but finally handed my pager in when my clinical privileges with Country Health SA expired last year, much to my wife's delight. In the post-arrest time, I attended over 40 RERN incidents. In the aftermath of that 6 months, I knew I definitely had some deficits. Perhaps the most debilitating from my point of view was loss of smell, the sense of smell. Food just didn't taste right, and neither did the wine. And I thought initially that was just hospital food, but when I got home to my wife's cooking, it was very definite that I had lost my sense of smell. I conclude that this happened actually at the face plant when the head hit the ground and the frontal lobes kept moving forward and sheared off the olfactory nerves as they travelled through the cribriform plate into the nose. Fortunately, I can still use the other part of taste, and that is the tongue and mouthfeel, and so I can pick most things that I'm eating, but we haven't done a blind trial yet to see if I can identify what I'm being fed. The other things that have happened that do disturb me a little is my short-term memory loss has escalated. Word finding and name finding, more importantly, has been impaired. And if my thought or action train is interrupted, I have to go back to the beginning and start again. Now, all this sounds like normal ageing, but I feel that my brain probably aged 4 or 5 years during the event and during the convalescence. I must accept also that the rest of me is now 5 years older, and retirement is a word that keeps pushing into my consciousness. Being a survivor is difficult to assess, mainly because of the large amount of anterograde amnesia, probably attributed to the midazolam as much as anything else. So I still have part of my brain that doesn't believe I've had a heart attack or a cardiac arrest, but there is a scar on my chest. My thanks go out to the members of our ambulance, the emergency services, and the retrieval team who so capably adapted to the escalation of the life threats on that, for them, an unforgivable day. Thank you.